I am the Managing Director of Clubfoot Solutions. Our founder, Jose Morcuende, is here. And I want to thank Jose for coming up here to do this talk here today. I also want to introduce some people for being here today. So we've got YVvan, our guest of honor right here. You want to thank YVvan? So it's a little bit of a story about YVvan. I'm starting with him first, and then you'll kind of see why I started with him first. So YVvan came here, what, 7 years ago now, right?
Yep, 2016.
Yeah, 2016. From a church mission. They found him in Africa, the Ivory Coast, and Dr. Morcuende was his treating physician. So he came over to Iowa, and then he was in Amy Northrup, we're his host family, and he would fly angel flights back and forth for how many casts, Jose? Was it 10 or so with them? Yeah, so he was a little bit older. 10 or so casts, and Reeves and Amy were so in love with YVvan that they decided to adopt him. You know, so they've had YVvan now for 7 years and just given him a life. But you know, the thing about our mission and living on Dr. Ponsetti's legacy, as we all know, was he wanted this method, the Ponsetti method, to be throughout the world. And YVvan is a living little boy living that right now, and he's very lucky, and I think he knows that, because still in these low-resource countries, it's about 30% that are getting directly. So you have millions of people around the world in low-resource countries that are walking on the tops of their feet. You know, they can't go to school, they can't work, they can't do those type of things. So we thought it was really important because we have a relation with YVvan, that he comes here and you can see a little thriving young boy and think about our mission at Clubfoot Solutions and the way that we work. Jose developed our brace there. Obviously, everybody knows that Dr. Ponsetti developed the Ponsetti technique at the University of Iowa. And the MD brace was developed there too. And Jose developed the Iowa brace, and all the profit, not all the profit, but the majority of the profit that we use, besides our salaries and stuff that come out of it, of the Iowa brace, go to help children like YVvan in low-resource countries obtain a brace. And we were just talking to Jim Mercir, who I'll introduce here in a second, about this. We've got our nonprofit to the point to where I can talk to any donor and say, hey, if you want to donate $25, kind of like our Footprints of Hope campaign today, that cost will go to 100% of that cost will go to a child in need out there who needs a brace. So that's kind of how our mission works at Clubfoot Solutions. So, but we look at little guys like YVvan every day and think about how we're helping them do that. And I'll talk a little bit about with Jose here too. I also want to introduce Clay Curts. Clay's over here. It's an interesting story with Clay. So Clay was treated by Dr. Ponsetti. All right, 21 years, right, Mom? 22 years ago today, all right? So, didn't know he was even going to be Clubfoot, right? He was born, right? Had no idea. From here in Illinois, from Monet down the road here. And it was interesting. So when we did the campaign with NASCAR, our driver, Joey Gase, called me and said, hey, I've got a driver who I raced against on some of the lower circuits who had Clubfoot. I'm like, oh my gosh, this is crazy. So I got a hold of Clay, and they said, yeah, it was treated by Dr. Ponsetti. I'm like, well, it's really crazy. Right? So we've got Clay involved in helping out, and the great thing about Clay is he's had no problems. So 21 years, and as most of the doctors here know, 21 years ago, most of it was being treated by surgery. And most of those people, as we'll talk about Jim here in a second, have had problems in multiple surgeries and that type of stuff. Clay works at a railroad, on his feet all day long, and has had zero problems. You know, so there's a lot of 22-year-olds out there that weren't treated with the Ponsetti method, they might have some surgery 20-some years ago, that aren't living the life that you're living right now. They're having a lot of complications and problems. So that's why this method and Dr. Ponsetti's legacy is so important to us, and Jose's dedicated his life to bring this method throughout the world. That we want to see people living like Clay is living, without having any worries about their feet and surgeries and that type of stuff. So, next person I want to introduce is Jim Mercir. Jim's right here. Jim was a 10-year Major League Baseball pitcher. He had clubfoot as a child, but he was surgically corrected, and has had a lot of problems over the years. How many surgeries did he have? 9 surgeries over the years with his clubfoot correction. So when we started this mission, we were looking for advocates out there that that could help us with their platforms and that type of stuff. So Jim was one of those advocates that could help us. Freddie Sanchez played Major League Baseball too, and he's helped us over the years and some of that type of stuff. And there's people like Troy Aikman, Christy Yamaguchi, Mia Hamm. There's a lot of athletes out there that have done a lot of wonderful things to bring clubfoot awareness. So Jim has really helped us by his talks that he's given about how important the pond setting method is, just because of the complications that he had. And obviously had a great career in the MLB for 10 years, but he still had problems, all right, that he's facing right now at this age, where he's at now in his life, that he wants to make sure every child gets treated like Clay got treated 22 years ago. So Jim's going to say a few words before we introduce Jose, but I want to thank everybody for coming here. I want to thank Dr. Ibram and Dr. Carl for our event over at the Children's Hospital today. It was wonderful. So great seeing those. Let's get the hand on that. Those kids over there signing the car and creating some clubfoot awareness for us, and it was just great. So Jim, I'll give you the floor. And
I have a disclaimer first, because I know, as one of you doctors know, that family history, sometimes they're not too sure and they kind of tell you a story. So I'm going to give you as best as I know what happened to me as a child. So when I was born, I had right club foot. My parents took me, I was in the hospital, went to the doctor, and the first thing they did, within the year, I had an Achilles heel surgery. Then I had the bars with the boots on to help me out. Now this is where it gets a little iffy. My parents told me that my doctor passed away. They sent me on to another doctor, and that doctor basically said, "Oh, he's fine," and sent me on my way. And I was fine for a bunch of years. My mother said I was like a crazy kid. I was all over the place, always very athletic. But when I turned 6 or 7 years old, they started to notice that my foot was turning a little bit, and I was also really running on that right foot, on the ball on my foot. And they were concerned, but I told them, nothing hurt, everything was fine, but it kept getting worse. Finally, they brought me to the doctor out on Long Island. The doctor's name was Dr. Palsner, and he said, he needs to be reconstructed. It's just going to get worse. We can't do anything about it. So I had the foot reconstructed. When I came out of surgery and everything was fine, I realized I knew I was different. I was about 8 years old. So I played sports, even at 7, played everything, loved it. I knew at that time that I could no longer play football because I wasn't going to be allowed because they were scared about my leg. Hockey, which I loved being on the ice even at that early age, could no longer do it because my ankle collapsed now. I couldn't wear skates and do it properly. And basketball I tried because I just want to try any sport I could. I damaged my ACL because I could no longer cut or move around like I used to. But the biggest thing I think as a child was the fact that I looked different. So before I was 7 and had that surgery, my calf was a little smaller. And you really had to look to notice it wasn't that big of a deal. But after the surgery, when I had my ankle fused, I could no longer build up that calf muscle. So it was a big deal. It was at the point where in the summertime, I was like, oh no, now I gotta wear shorts. And I didn't want to do that because I looked different. But I got over that, played sports, realized that baseball was the only thing that I could really do and do well. And, played at different levels outside with friends. And the thing was, baseball was always my passion, so it was a great thing because I loved that more than anything else. I got to high school. I was always a small kid, so I wasn't getting a lot of scouts' attention until my senior year because I grew and started throwing the ball over 90 miles an hour. But they looked at me on the mound and they saw a guy throw a pitch and then walk around limping. I thought this guy's going to get hurt, so I was, they were telling me you might be in the 50th round, so I decided to go to college. I went to college, I excelled, and at that point, they saw that I was able to do it, so I got drafted by the Seattle Mariners to play Major League Baseball. And at that time, between 18 and 25, I really didn't have that much problems. You're young, you're resilient. After that, I started having difficulty with my knees. My right knee, just because I damaged it already, so I had cartilage and meniscus problems. And then my left knee started going bad just because I overused it. So everything I did to be a professional player was, compensate for that right leg. So it was even upper body, arms, legs. That left leg, started giving me problems. And then when I was a professional, I can remember the exact day, the pinnacle of my career, I was playing against the Yankees in the playoffs. I have Derek Jeter up, throw him a fastball inside, jams him, and goes to first base, and I go to run and cover first. And when I step on the bag on my left knee, it feels like somebody stabs me in the knee. And the reason why it happened is because of my club foot. Because when you're a pitcher and you're covering that first base, you're supposed to go with your inside leg, so it's always going to be the right leg. But over the years of doing it, every time I did it, I could feel my knee, and sometimes I would injure myself because the base is about this big. So when I would step on it, it was just awkward, and I would hurt myself. So I knew that I have to start hitting in the bag with my left foot. It's not really orthodox, and I ended up hurting that knee. That next day, because it's professional sports, they're like, how do you feel? And they told me to throw a bullpen, and anybody with a good eye would look and see I couldn't even land on my leg, but they were going to question me, so I said, well, I need help. So they put a Novocaine shot in that knee, and I went out and pitched 3 innings. Well, I'm sure more damage was done. A year and a half later, I was just playing with my son. I jumped up on a little thing and just ruptured the patella tendon. And so that was, and once again, I got rushed. So after rupturing the patella tendon, 5.5 months after that surgery, I got back to the big leagues because they needed my help. Had the worst year of my career, and also started hurting my right knee again because now I had to rehab, and that was bothered. So the last 5 years of my career, I really had a lot of leg problems because of the knees. But that's not even the biggest thing. So I love working with Clubfoot Solutions and Pond Setting International, not just for the kids, because I know, of course, every kid, you want them to be healthy, happy, and everything. But I know when they get older, I know now I have back problems, hip problems, all these problems because I didn't have the opportunity to get the Pond Setting method. So I just want them when they get older, when they reach their 50s, not to be in constant pain and realize the things that they need to do to be healthy. So I think it's a low cost, easy solution that I just think needs more attention. So right now I'd like to introduce Dr. Jose Morcuende. He's going to tell you a little bit more about what's going on in the clubfoot world today.
Thank you.
All right. So thank you, everybody. PHDYvan, how are you doing, buddy? Well, thank you, Jim, and thank you, everybody, for being here. And thank you for being here. You know a lot about Dr. Mercir. These are my disclosures. Now, we all have to remember Dr. Mercir. Okay, so he was a wonderful man. Most of his life was in research. Now, he published his paper in 1963. His first patient was in 1948, so he didn't rush like most people. 6 months later, you do a new technique or something, and then you are publishing and presenting this thing. It was 12-year follow-up. And unfortunately, it really didn't catch up in the orthopedic community until the 90s, late 90s, 96, when he published his book and a paper by Fred Ditz, which was one of our doctors, professors, passed away a few years ago, with a paper on the long-term follow-up of Clubfoot. And I think it was the combination of that paper and Dr. Mercir's book that start calling the attention of the orthopedic communities about, how to treat Clubfoot without the need for surgery. So we are going to be talking about a little bit of current concepts, so you are all familiar with that. But I think this is very important because I think there's a lot of misconceptions about Clubfoot. So the first is to understand the biology of Clubfoot. Well, why Clubfoot happened, right? So, sorry.
Yes.
So everybody, this is a Dr. Mercir dissection. So when he started studying Clubfoot to come up with the method that now has his name, he wanted to understand, Clubfoot at the basic level. He was a clinician scientist, so he did dissection. So then you can see all these deformities, and unfortunately, most people think that this is what the problem is. And in order to correct this deformity, you have to cut it around and put it straight because they are in different positions. But the thing is that biologically, the bones have zero problems. The bones are not affected by the problem. And this is a study, an MRI study by Shafiq Pirani, published a few years ago, in which he did an MRI before treatment. You can see this is exactly the same. And then in the middle of treatment, and then after the last part of the treatment, the last cast, and you can see that the bones remodel perfectly fine. The alignment is normal. So these bones biologically are responding like any bone that we know. You have a EDH, at the location of the hip, and the socket is flat and the hip is over here. You put it back together, and eventually they just develop normal. That's how the musculoskeletal system works. So there's no biological abnormalities in the bone fiber. So the foot has to be twisted this way for some of the reason, and that is what Dr. Poncetti did. So this is very important to understand that this is not a malformation. A malformation is when there's a deformity that happened the first 9 weeks of development, which is when the baby is formed. The foot is formed, all the ligaments are there, everything is there. Things start happening after the embryonic period. And then what happens is that the soft tissues in the lower extremity are affected by some biological glitch. We know now that there's a Clubfoot associated to a duplication of a gene called TBX4. And when you have a duplication in that gene, you have bilateral club feet, and they are very severe actually. I have a few families with that. And so there's a biological glitch. And this is an ultrasound of a 16, 17 weeks old fetus. You can see the deformity. It has nothing to do with pressure. The kid is, in the water, swimming pretty much. And then deformity is there. And then when you do dissections with the Dr. Poncetti, then you see this increase on cellularity, all the cells and all these tissues. And that is what makes the lower extremity to be less flexible. This study is from Dr. Ippolito from Italy. He was a fellow with Dr. Poncetti in the 70s. And what you can see here is a kid just before treatment, is a newborn, and they were able to go through the IRB and accept that they can do an MRI and the anesthesia in a newborn. How they did that in Italy, I don't know, but they did it. And then you can see the difference between the normal size of the bone, of the muscles, and the one that is affected with the clubfoot. I mean, it's almost half of the size. And if you look at the signal in the bone, in the muscles, it's affected. This is the anterior tibial tendon, and these are the extensors. And this is almost like fibrosis, lipo, something. So these muscles are sick, and that is what happened. And this is another issue. Relapses are not because the anterior tibial tendon has a dynamic supination. That is a complete mistake, because this muscle has no hyperactivity. So this is what the problem of Clubfoot is. This is the problem, is that these muscles are built with less flexibility because they have more stuff, and they are smaller because they cannot grow properly. And during development, and the bones are normal, so the bone is growing, and the muscle has to grow, and the ligaments at the same rate. Otherwise, they are behind. If they get behind, they get contracted. If they contracted, then they develop deformity. And so that is how this happens. So the problem of clubfoot is actually not a problem of the foot. It's a problem of the development of the leg. So when you look at a muscle, and this is the calf muscle, you can see how it's smaller, is less thick, it has less muscle, and you can see that the Achilles tendon over here is much thicker than the other side, and so it has less flexibility. Okay, and that is the main problem with clubfoot. It's a smaller muscle and less flexibility. This is a patient of Dr. Poncetti when he was maybe 10 or 12. You can see the difference between these two, the normal side and the abnormal side. This is actually the same patient at the age of 50, and still the leg didn't grow enough. So this is something that is there, and it's going to be there for the rest of the life of the patient, no matter if you are a baseball player in the big league is not going to grow. It's always going to be small. So now there's another component in the soft tissues in the lower extremities. Okay, and this is something that we need to start thinking about. So it's like, well, I did it normally, it didn't work. And then you have a foot like this. We call it now complex clubfoot. I mean, you can see here that, the vascular supply is affected dramatically. Okay, I mean, this is not a compartment syndrome, but it behaves like a compartment syndrome because there's no exchange of oxygen because the veins are not taking the blood out. Okay, so when you see this, that is a big problem. And so what happened with that happening? Well, one of the reasons is because the RD sometimes in some patients is abnormal. In this MRI study by Curts and the group of dogs, and this one is the same, you can see that there's some abnormality. So this soft tissue abnormality is also affecting the blood vessels. And that's why when you are treating a clubfoot, and then you are doing a casting, and then after, I don't know, first cast or third cast or something, start blowing up, and you're like, oh, what happened here? Well, this is what happened, is that you are stretching too much. You are passing that limit of the blood supply to be working properly. And the problem is, if you get to that situation, and this paper, which is called resistant clubfoot, what happened then is to practically kill the muscle. If it was already affected, then you can actually get to this kind of situation. And you can imagine that this is not recoverable. That muscle is there, and that you are going. I mean, you know that you are going to have relapses over and over and over. The foot is going to be skinny. You have to be doing this and doing that. So, and this happened because this happened when you're doing the casting. And so that's why the casting technique is so important. So now this abnormality stage. This is a kid. He's 5 or 6 years old. He's out of the brace. Clinically he's not great. Muscle-wise, is about. And so what you want with this deformity, with Clubfoot, is you want to let the kids to be active. The muscle requires stretching in order to grow. If you use anything during the day that inhibits the growth of the muscle, it's going to get worse. It's not going to prevent relapses, and it's going to make it worse. Just using an AFO in whatever other pathology that we have makes the leg skinny. So if you put that on top of the muscle being affected already, then it's going to be worse. You can only keep the flexibility at night when it is asleep, and the only way to do that is by keeping the abduction brace. An AFO is not a stretching. The only way to stretch is the foot abduction brace, because it's a dynamic brace. What it does is the kid is moving, and every time it's moving, it's stretching those muscles. And when it's sleeping, it's like this way, and then an hour later, it's this way. So during that time, and there's relaxation. And so that's the way to keep the flexibility. Anything you do during the day is going to inhibit that development dramatically. So the concept here, which I think is extremely important to understand, and when you are in your practice and thinking about what to do with this case, is that it's not a clubfoot problem, it's not a foot problem, but forget about the foot. You have to think about how is the development of the leg, and how is the flexibility, and how can I keep the flexibility of these children? Because that is what the problem is. It's in the flexibility. So it's a flexibility issue, clubfoot. It's not a deformity issue. And I think that's the main concept that we need to understand. Now the second is understanding the human mechanics. So it's like, how do you correct the deformity, which is what Dr. Passetti came up, 65 years ago. And the thing is that what he realized is that you can correct the deformity if you understand how the normal foot moves, which a clubfoot is the same, just it's tighter. And it's all based on how the subtalar joint is moving. For the medical people, they understand this is when you move your foot sideways. That's the subtalar joint. Going up and down is your ankle. So the clubfoot is mostly the subtalar joint not moving properly because it's tight because of the muscles. So the key here is that the heel bone and the bones in the middle of the foot are all pretty much a solid block. There's no mobility in these joints, very little. It's like 1 degree and they go like this. They are not moving like that. So the whole foot moves underneath the ankle bone. Okay, so for correcting clubfoot, which means stretching the muscles and tendons, you move the whole foot to be stretching slowly. And that's what Dr. Posetti realized back in the days. And then you can see that when you move the foot down and in, the heel bone is in this position. And as you are moving the foot down, up, it goes into dorsiflexion and abduction is called. So this is the normal motion, and the clubfoot follows the same motion. It's just that the muscles are tight on this side. Okay, if you don't allow this to happen, to move the heel bone with the rest of the foot together, then you cannot correct the deformity. Okay? And that is what happened with the method that was used for many, many years. So how do you do that? Well, you put your little thumb here. On that bone is the talus, and this is very important how you place your thumb, because if your thumb is a little bit down, you are going to block the calcaneus, the heel bone. And our thumb is about, what, 1.5 centimeters surface area. The head of the talus in a baby is 5 millimeters. So if you put your thumb all the way here, which is usually the mistake, then you are blocking the bone for moving. And then it's a resistant clubfoot. It doesn't work. And it doesn't work because, you know, that's a technique issue, right? And that's the problem. What was called the Klein method is that you put your thumb right in the middle of the foot, and so you cannot keep it going. And the same thing with the cast. You cannot move that foot because you are blocking yourself. And that was the main reason why this never worked, or 99% of the time. And then it's like, well, this is a very stiff foot. It needs surgery after 20 or 30 casts and waiting for the kid to be 7 months old. Okay, so this was the mistake. And the mistake is when you are doing the Posetti method, to put the thumb so it does the same thing. And that is critical. Now, there's one component in clubfoot that is very important, which is a high arch. And in order to correct that deformity, you have to go up with your first toe. Okay? And if you turn around like this case, which was what it used to be done before, and unfortunately, when people do the casting without, you know, understanding, they turn it around, then your high arch stays very high. And so you are not correcting the deformity, in which case then it's like, oh, this foot is very resistant, it's going to need surgery. Okay, so this one is very important. Now, elevating the first way doesn't mean that you have to supinate the foot and put it perpendicular to the tibia, which I have seen some cases, you know, the cast, and it's like the foot is like twisted completely the other way. It's just elevating the first way. Okay, so that is extremely important, because otherwise you break the midfoot too. Now, when you are correcting, if you don't put a counter pressure somewhere, what you're doing is you are twisting the ankle. Have you ever seen a lateral malleolar line posteriorly? Many times, right? But that happened because you are twisting the ankle. Now the foot looks like it's straight, but the ankle is, you know, 60 degrees this way. So that's why you have to put pressure on the head of the talus here, carefully, to prevent that from happening. And this is a study by Polito, and you can see here the results of doing that, just twisting the leg without counter pressure. So these are very, very important points in order to be successful with the method. Now the third aspect is you have to apply the method properly. It's not rocket science, okay? I mean, really, this is not that complicated. But the Posetti method is a specific way that they're doing the manipulation, they're doing the casting, a specific way to prevent relapses, which is with the brace, and also treating relapses, which is the major issue today in the United States. So the principles of the treatment are extremely simple. You correct the deformity with casting means you are stretching. No matter if the kid is 1 day old, or if I relapse at 2 years old, or I relapse at 5 years old, or it's a kid that never been treated for 5 years or 3 years like Ivan, or 20 years old. You always have to correct the deformity with casting. Then you have to get dorsiflexion, means you have to get the full flexibility of the ankle, in which case you have to do a tenotomy, just keeping the tendon, right? And then you have to maintain that flexibility that you obtain with the casting. Using the brace at night for 4 to 5 years, and with that you decrease the chances of relapses 95%. And when the kid is older and they don't tolerate the brace anymore, but you have to do everything to get them to the 4 or 5 years of age. In my practice, I would say 95%, actually 95% of the kids are able to get them to use the brace until 4 or 5. But you have to make an effort to convince the family. The mistake is to say, oh, the parents don't want to use it, it's their problem, now I fix it, which is what happened, unfortunately. The precision required is very, very high. So you have to learn how to put the fingers in the right place, how much you can stretch, and then you have to be very, very precise in the molding on the casting. You are molding a foot. You are making it new from being completely twisted to have a normal shape. So if the casting is not done properly, like here, you can see, if you do it that way, 90% of the time, you can get the foot corrected with 5 casts. And you will see the data here in a minute. And it's critical to do it in a clinical setting that allows you to do properly, and that is another problem. So what is the issue? Well, you have a kid that is born with a foot like this, and you want a kid with a foot that it looks absolutely normal, and 25 years, 22 years later, it's going to keep absolutely normal, right? And you have 2 choices. You have your knowledge, your hand, and an instrument, in which case it's a knife. And then you have your knowledge, your hand, and a different instrument with each plaster cast. Now, if you decide to go this route, then you have a team, and you have a special place, and you have anesthesiology. So you have to require that to do it properly, and the kid is not bouncing around and crying or nothing, yeah, because he's under anesthesia. Now, what happens when you go through this route is that, oh, that's just plaster cast. It can be done anywhere. And it can be done, actually, by anybody. And so, what happened then is that things don't go well. The Ponseti casting is teamwork, and it has to be done as precise as the surgery. The deformity is the same. The same ligaments, the same tendons, the same everything. It's just that you are using a different instrument, but the complexity is the same one way or the other. So if you don't use the same attention to the detail, it's not going to work. And so you need somebody that helps you, that has experience and developed experience with you. I will say that what I see from my traveling and everything is that many times the person doing the casting is the nurse or the cast technician by itself, not the doctor, because you need help. Nobody can do it by itself. And then you need your parents to make the baby to be relaxed. It's impossible to do a good casting and good stretching. The kid's crying. Now, it's not crying here. Well, you have to make an effort so it's not crying over here. So unless you do it in this clinical setting, in a room that you're by yourself, instead of being in the cash room of the department that there's another 5 beds and the saw in an adult and everybody running around or something, there's no way for the kid to be relaxed, and there's no way to get correction. And then it's 10 casts later, it's like, oh, this foot is very stiff. Well, it's very stiff because, you know, the kid is not relaxed to do it. So this is critical to develop a Clubfoot clinic dedicated to Clubfoot, the same way that when you have your day of surgery, you just do surgery, okay? So, I just showed you a few pictures here of Clubfoot Ponseti treatment, okay? So there are people using shoreline cast, which has done nothing. The cast start filling up. This is from Young December. I just got this one actually 2 days ago. And so do you think these cats are the same that these cats over here? No, they are not. And that's why it fails. So it's not the food that's resistant or severe, it's your casting technique. If you don't do this way, there's no way you are going to get good results. Okay? So, and that is the result of potential problem with casting. You know, ulcers, those overlapping, a rocket bottom deformity, which is very common, a complex clubfoot and a super complex clubfoot. So this foot has very little chances, with all the swelling and the muscles affected as the kid grows, to have a normal function. It's always going to be tight, and it's going to be a struggle for years. I can tell you because I see many of these cases. Now, are I making this up? No, I'm not making this up. Okay, this is a systematic review by this group. Xiao is a friend of mine from China, and they just decided in 2014 to look at all the papers on clubfoot on the Ponseri method. And what they found is that the clinical variation means, oh, I get this much result, I need 10 casts, I need this and that, is because of deviation of the technique at every single aspect. So you read papers, then one, oh, I use the brace only for 2 weeks, or I do the brace for this, I do 20% tenotomies, I don't do this and that. And so if you don't follow the method, then you don't get the results that are the method provides, which is actually amazing. And Dr. Ponseri was just a genius from me. This is another paper. This is the group of dogs that now he's in Florida. And the group from this group is the group from Denver, Colorado. So they compared their statistics on the two places. And so what they found is that the dogs had 2 surgeries out of 91, and there were 2 transfers, and the group in Denver had 47% surgical releases because they have to cut everything in order to get the foot corrected. Now this same group, Nancy Miller was a fellow in our place back in the days, actually 1 year before I came to the United States 3 years ago. And so they said, well, this cannot happen. So Gaia Georgiopoulos came to Iowa for a couple of weeks, and then, you know, we went through the casting and the fix and so forth, like Becker did here, and then they published another paper, follow-up paper, and this is when they came and implemented a Clubfoot clinic dedicated to Clubfoot 1 day a week. And these are the number of surgeries before, they explained 0 surgeries. Same people, just doing it right. So what's happening is that people are not doing actually a good job in the United States. We did this study asking the members of POSNA. POSNA is the Orthopedic Society of North America, and we got a bunch of responses. Everybody was saying, I do Ponseri, but I do Ponseri that only 34% recommend the brace until 4. When everybody has a bunch of relapses. What is the principle for treatment of clubfoot? Anytime you have a baby you want or a relapse, you have to do a stretching of the muscles, because otherwise they are not getting stretched. And 45% didn't do casting before, so you don't casting before. This is what the people say. I'm not making it up. Then the foot, you do the transfer, and the foot still is like this. It's like, well, we need to do something. Then you have to cut something to put it straight. So 43% did surgical releases like it happened before. This is 2017. Okay, this is not like 50 years ago. Now, there was a study by Sions that in 2010 that looked at first year of life results and surgery. And you can see here, just remember, 2000 was when the Ponseri method program started, and we started teaching actually in 99 in Iowa. So up to 2000, 80% of the patients pretty much require surgery. Then people start coming to Iowa once a year and they start learning the Ponseri method. And in 5 years, 6 years, it went down 85% in the first year of life. So most people were able to correct most feet, not all of them, with some problems that we saw. But the problem is we follow up this study and say, well, you don't finish the treatment of Clubfoot is 1 year of age. You finish the treatment of Clubfoot when the kid is finished growing, which is 18 years of age. So we look at the same database. This is a national database. It's called Kids Database. And we just went, we are now doing 19. So we haven't published the paper. It was presented at American Academy on 19. We are doing 16 and 19 right now. But what we saw until here is that the number of surgeries in black, which is the first year of life, yes, it went down 90%. The number of surgeries after the first year of life is exactly the same today in the United States. So when people are able to get to 1 year and then relapses, not working properly, blah, 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 and it's like, okay, we need to do surgery. So when you put these numbers together with these numbers, you realize that in the United States we have a problem here. Big problem. Why? Come on. Let's see. Sometimes you have to go. So, what's the problem? And Jim just give his personal experience. What are the long-term implications of surgery? Well, in a study by Dobbs, published in 2004, he followed these patients from the Shriners Hospital in St. Louis by the age of 30. And you can see here by the age of 30, pretty much almost everybody had arthritis in one joint or the other. Okay? And when you compare the series of Dobbs with Cochlear and this, which were exactly almost the same number of patients, and when you use the excellent, good, and 74% of the patients have poor, very poor results compared with the Ponseti method over here. And these are the patients that Dr. Ponseti treated back in the 50s, which actually he improved and refined the technique over the years. But this is what happens when you do surgery, right here. 75% of the patients will have problems and many surgeries. And these are the papers that are long-term follow-ups published in the literature, not too many, because one of the reasons why people don't publish papers on this is because the results are so bad that they don't want the department to say, okay, it's my department. But yeah, when you look at the numbers up to the age of 10, most people are doing fine. The same story that Jim, 7, 8, you were just running around or something, and then when you reach maturity, things start getting busy, and then you go down to 30% good results. Okay, and the Ponseti method, this is 50-year follow-up, they stay the same. 80 to 90% of people have no problem, but you would be just fine. You could be just right here. Okay, so this is a big deal. Okay. And the problem is, this problem with the foot affects the quality of life. We as orthopedic surgeons say, hey, hi Jim, how are you doing today? You come to clinic, how's your foot? Oh, I'm doing fine. It's hurting? No, not too much. I use inserts and I'm just managing or something. Yeah, fine. But do you ask the question, okay, what can you do during the day? Are you able to play tennis? Are you able to play baseball? Are you able to hike? Are you able to run a mile? Are you able to do anything? And they say, no, if I stay more than an hour standing or two, then I'm screwed for 3 days. It hurts so much, right? But we don't ask that kind of question. So Dobbs asked the question using the SF-36, which is a test asking for quality of life. And here, these are 30 years old people, okay, that had a quality of life affected as much as people with all of these pathologies. I mean, people with chronic heart failure is the same. Their quality of life sucks because they can do nothing. It's like you have chronic heart failure, yeah, you are sitting, but then you have to go 1 flight of stairs, you can't because your heart doesn't give you. Well, in this case, you cannot do it because you want to be hurting for the rest of the day or 3 days. So this is very important to keep in mind. So every time you do surgery in Clubfoot, you know that you are sending the people to this pathway. Now, we all face relapses, and the relapses happen because there's a biological problem. Now, in the paper of Dr. Ponset in '63, there were things that he refined over the years. Number one, he put the cast to 30 or 40. Now we know that 60 is better. You stretch more. He only did 70% tenotomies. Now you do in everybody, other than just a couple kids that are flexible and you don't need to. Everybody needs a tenotomy clubfoot. His average was 7.6. Now you will see the data is different. The shoes were put at 30, 40, like when you do the abduction, and so the change to 60 made a difference. And when he started in the first few years of life of his practice, in 48 to 55 or so, he only used the brace for 21 months average. The kid, you know, it was the first time he was doing the method, so the kid was 2 years old, kind of, and he's walking around, he looks good, and, you know, a little bit similar to what happened to you. And he's like, okay, well, you don't need the brace anymore. And that was the main issue, because what happened is that he had a lot of relapses. You just stop the brace at 2, 6 or 8 months later, 55% of the kids are going to relapse. When you do up to the age of 3, 20%, and then by 4, 4.5, 10%, and then 1% is 7. So we know that if you get here, you have very little chances of having relapses again. And actually, he said that in his paper. He said, you need to go with a brace until 5 years of age. That is 1963, because he saw the problem over here. And that's the reason for using and pushing the parents and helping the parents to go to 5, because then when you are here, it's only maybe 2 or 3% at the most. So these are the data. Melinda is a resident. I was grooming her to be following up, but he decided to come. So he just finished. He's finishing tomorrow. But he did very good studies. So he put together all the patients that we treated from 1948 to 2013. So, and we chose 13. I mean, he started like 3 years ago. So we wanted all the patients to be out of the brace. So it was 1,500 plus patients, more than 5 years. The numbers are the same. This is 65 years of life. It's all the patients, okay, from Dr. Morcel and myself. So this is the key. In these 65 years, the average number of casts is 5.3 with a standard deviation of 2. In 65 years, I want to say it again, the number of casts in 65 years is 5.3. Only 7.8 require more than 7 casts in 65 years, okay? If they have previous treatment, and you know we do a lot of them, they don't need another 10 casts plus the 10 casts that they had before. When you do a good casting, they need 3 or 4 more to get them corrected, okay? Now we do 95% tenotomies now, and sometimes half of them of the previous treatment require that. So just remember these numbers, because this is the key based on all the information from before. There's not a lot of different severity in clubfoot. There's no resistant clubfoot. It doesn't exist. It's the casting technique. Only 9% require more than 7 casts. And I have one kid that required 25. His name is Grayson, okay? And another one called Henry, which had like 14 or 15 in our hands. But those are like the 2 names that I remember, not too many. So most of the patients with clubfoot, idiopathic clubfoot, okay, can be corrected with an average of 5 to 6 casts. And it's all not because of the severity. There's not a lot of different severity. What is different is your hand, is your casting technique. If you have a perfected, properly performed, very meticulous, very careful with the swine and everything, you can get mostly corrected with 5 to 6 casts. So when you read papers about, different graft severity and the resistant one and this and that, it's because people are not using a good casting technique. And you can see that the variation in the papers is all over the place. And this is, I think, the main problem that we are facing today. So relapses can be decreased. You can see here that if you get to 5, 6, the number of relapses, and this is the 65 years that we are, then it goes down dramatically. Now we have relapses 1, 2, or 3. I mean, there are families that don't follow the, but then you work with them. But the key here is that you have to work with them and make them understanding that the brace is critical. There's nothing statistically when the kid is treated, if it's 1 day old or 5 years old, if they have previous treatment, unless it's surgery, in which case it's different, but if they have been treated with casting and then we treat them with 3 or 4 more casts, then they behave the same. We change the cast every 4 or 5 days in some families because they come from other states and they have to be in Iowa City for the treatment time. And so we're trying to shorten, and if you do it a little bit shorter, that makes no difference. Yeah, number of casts made a difference, but remember, it's only 8%. Now, if they need 8%, there's more stiffness and there's more chances of relapses, and it's going to last longer, the relapse possibility. So those cases, you have to keep the family pushing to 5, and if they can go to 6, which is rare, but at least to 5, because then you decrease the chances of having to treat a relapse. And the main factor for relapses is the brace, 100%. And the brace is the critical component. So what is, when you do relapses, thinking about relapses, what are the most important factors for relapses? Prevention, prevention, and prevention. Without the brace, you are going to be facing a lot of relapses. So, what is the most important thing in relapses? In bracing, comfortable shoes. No matter what the company makes, or who is the company, or it's just comfortable shoes. If the kid is crying half of the night because the shoes are not comfortable, there's no way to get that family to 5. You guys are a little bit older, and I kind of got that part. The Dennis Brown splint things, the white boots thing, the Markel. I mean, those are torture for a baby. For all the kids, it's a little better because they have a little bit bigger, but for the babies, it's a disaster. So, whenever you choose to recommend to your parents what brace to use, please use the one that is the most comfortable, because then the results are much better, because the kids are not going to cry every night. I mean, that's just the point. The rest is just little numbers. You put the foot at 60, then you bend the bar a little bit, the distance, doesn't need to be this long, it has to be actually the shoulder width. It's not outside the shoulders. The center of the shoe has to be in the center of the shoulder, because if it is too wide, it's very difficult for the kids to move. And also, it can create external rotation of the tibia and genu valgus. So the bar doesn't need to be humongous. It has to be just the size of the shoulders. And with that, it works fine. This is a father, Dimeo Andrew, that had a clinic with Clubfoot, and when he did his PhD for biomechanics, decided to develop this model for checking how the brace works. And here you can see that the standard brace stretches everything, and you can see that the peroneus and the tibia anterior don't stretch because the foot is this way. So they get stronger, especially peroneals, because they get shorter, right? This is, if you do an AFO, yeah, there's a little stretches, but it's 90 degrees. And you need 15. So as soon as you put an AFO in a kid at night, you are going to lose the flexibility. And once you lose that, then the foot starts turning in, and then you are done. And some types of articulating braces, if they have too much flexibility, and this one specifically was the Dobbs articulating brace thing, it doesn't stretch as much because it's too much flexibility. So the best brace, the best configuration is an adduction brace with comfortable shoes, and then you know that you are in good shape. Now, some people like to use unilateral shoes. It's like, well, you only have one clubfoot, why do you need to use both? So just use one. So this study from Norway is very important because they compare, and these are not the best shoes, as you know. And unilateral one, you have to do the flexibility, so you have to put these straps and this one. And what you see when you do this, is you for 4 or 5 years, the kid is sleeping with this pressure for 10 hours, this is what you get. Because with this one, the kid is moving. with this one, there's no motion in the ankle. And so only 7% were normal. And all these have some mild, moderate, or severe. And there are some in the Clubfoot too. But the reason here too is because they only did 70% tenotomies. And the average guys, it was like 8 or 9. So the technique was no problem. So I think it can be improved. But definitely, you forget about this one and you concentrate here. Any unilateral foot, and when this is flat, it's flat for life. There's no way to recover a flat talus, ever. And there's never going to be flexibility in the ankle because it has to be round in order to do this, right? If it is flat, it's flat. So, so this is very important. So unilateral braces don't work. And the bracing is a partnership with the parents. You really have to become their coach. I'm not blaming because they are not using. Life is complicated for everybody. And sometimes life gives you curveballs and then the parents, have to deal with them. And then they don't use the brace because, life is complicated. Well, you don't have to blame them and say, okay, you have to help them because it's your responsibility. Your parents are working for you. Your responsibility is with a child that can do nothing. I mean, it's just a child. And so you have to work with the parents to be successful, and you have to make the parents successful. And they understand that when you have empathy and you are there to help them and don't blame them. And so this is critical. It's all psychology. It has nothing to do with numbers, but it's extremely important. In our practices, we are so busy that most of the time the problem is we don't have enough time to talk to parents. But you have to, because otherwise you have 50% relapse rate, which is going to take more of your time than just talking for 5 more minutes with these families, right? So what are the global implications of all this, okay? This is what, let's see. This is what you see in developing countries, as Todd was saying, and Ivan is an example. And this is, I go to many countries, and still this is a problem. There are probably millions of people like this. So the main problem of Clubfoot is not in our country or Europe. We have 4,000 cases. Europe has 4,000 cases. There's 250,000 cases average every year. And they are all in places that they have no money or no treatment, right? And so that's why the method is so important. Now, it's like, well, this works great for kids. What is amazing is that it works for any age. This is the first case that was treated outside the 3 to 5, 6 months. And it was like Monica Nogueira in Brazil. She came in 2001. She was with John Hessenberg doing a fellowship. And then she came for the course. She really got it. Went back to Brazil. And we worked with her to develop a program in Brazil. And then she faced this situation. 6 years old, came to her clinic like this. And it's like, he was set up for surgery. And it's like, okay, well, let me try a few casts and see what happened. 6 casts, not 20. No 15, 6. It went from there to here. 6 weeks. 6. And that is the clinical picture after the tenotomy. And I think she did a lengthening because at that time we didn't know that you can do tenotomies in older kids. These are the x-rays before. These are the x-rays after the casting. If I show you this picture, would you think that the foot was like that? It remodels very well. So if you can treat a 6 years old, how can you treat a 2 days old, or 5 days old, or a 1 year old, or a 3 years old? But that is not only that. This is a patient from Dr. Diego Ortiz. This is a patient from Venezuela. He lives in Colombia, and now with the problem with Venezuela, they get a lot of patients. So this is a 15 years old. She had surgery in Venezuela and then abandoned, and she came like this. And then he did the casting, and with 10 casts and a tenotomy, he got it to this point. This is even after surgical releases in a 15 years old. You know how old is the oldest patient that now Diego treats in Bogota? And he was in Iowa actually 2 weeks ago. Just say a number. Okay, 20. Who gives more? Like in an auction? Go up?
35.
35.
45.
45. Huh?
55. Really? What?
63. Wow. 63. He's putting a paper together. He has 85 cases of more than 20. 63. 10 calves. Not 20 or 30 or half a year. 63. So who is going to tell me that you cannot do a little paper? Okay. So, but the key here, oops. So the key here is that, and this is what I've been doing the last 20 years, is that the Ponseti method is not a casting technique, it's a method, and that method can be applied at a low global level. So the Ponseti method becomes a public health intervention for the treatment and prevention of disability worldwide, which is millions of people today. And so 5 doses like the polio, 3 kind of shots of little thingy, well 5, and then you get the food corrected and you will never ever again see these things ever in the world. And so that's why the Ponseti method is such an amazing thing. Oops. Now it's working. So because of that public health concept, the University of Iowa, the Board of Regents in Iowa, allowed the University of Iowa, which is a public institution, as you know, to create Ponseti International. It's just to create an association for teaching and development of programs for the disability. And now you have to change your approach in the meaning of it's just not just training people to do a little casting, it's to develop the program, to identify the people, to bring it to the clinic, to treat them and to treat the other one and so forth. So you have to develop a real program. So we were very lucky in 2012, 2015 that the USAID gave us a grant to develop the model of how to do these programs. And so we did a program in Peru, Nigeria, Pakistan, to have the 3 continents and different cultural issues and so forth. Now, just for you as a perspective, in Nigeria there's 200 plus million people. You know how many orthopedic surgeons are in Nigeria? 1,000. In the United States we are what, 300 plus? How many orthopedics are we? Like 25,000 or something? So you can see that, well, and in Pakistan it's say 200 million people, another 1,000 or 1,200 people, 100 orthopedic surgeons. Now after the 3 years, they developed 45 clinics dedicated one day to just Clubfoot. And they have published a lot of papers after the program. And so the critical component is the training. I mean, if you don't know how to do it, then you don't have a program. Okay? But the key in the training is the fellowship. 2-day course, 1.5-day course, half a course at the Orlando, if posting is not going to make it. And that's been the problem in the United States, is people have not gotten very good training because it takes time. So this is a personal issue. I work with Dr. Ponseti. I came in 91, and so I worked with him, finished my residence in 2001, and before I was a fellow, so I helped him too. And then I was with him from 2001 to 2009, that he passed away. And I help him in the clinic every Monday, Wednesday, and Friday. And I will be doing the casting with him and with Maria, the nurse. Every single time I did the casting with him, and if it's bilateral in both of the casts, he will make a comment about my casting technique. Every single time. And I'm not kidding, it's true. So too slow, too tight, too loose, too something. But I think I got pretty good hands after that. And I can do, I think, a relatively good cast. Relatively good cast. Second thing that Dr. Ponseti, he was in the last maybe 2 years of his life, 90 something. And one day we are doing the casting, and then he start doing the molding stuff, and he goes and say to Maria and myself, say, you know, guys, I feel that now I can do a very good cast for Clubfoot. 90 something, and they're like, oh my god. And that's why I say that I think I can do a pretty good cast, because I haven't been to 95. So the training is very important. These one-day course kind of things are only introductory. And that was, I think that's been the major problem in teaching. I think many people, I mean, we are orthopedic surgeons, we are very smart, we have done casting for other things, and, you know, we understand Clubfoot, we know the nerves and everything. The casting technique is very tricky. I mean, Rebecca was there, I mean, we spent hours doing casting in the little foot models, and then you start feeling much better, and I think, I don't know, you can, you know, you can give your experience, but the experience I have, and I have people coming every 2 weeks to visit the center, everybody feels that, you know, they improve the technique, because you have to learn if somebody have done it many times. So this is very, very important for successful, because it's a global program, you need a register or something to know what's going on. And so the bioinformatics people developed the international Clubfoot registry. In many countries, there's no records or nothing. You know, the patient was there, you do the cast, and, you know, he come back next week or something. And so they use it a lot. So right now it's being used by over 100 countries, with many people using, you know, having their own accounts. And so far, this is about maybe a month or two ago, there was already 100,000 plus patients in the ICR. It's becoming a huge resource for research. I cannot even keep track already of every country with their patient presenting in their meetings and so forth. I haven't tapped onto this number yet. I start working on kind of publishing, you know, all the registry. But the thing is, we did a little bit of, you know, kind of quick. Of all these, the average number of casts is 6 in 120,000. So if you do it right, it can happen. Because you want to integrate the Ponseti method into the healthcare system, not create a parallel system, which is happening with other organizations, other NGOs. Then you work with the orthopedic societies, so that way they endorse the method, and then the people start using it, because it's kind of hard for the professional organizations to actually endorse. We are endorsed by, Ponseti is endorsed by the American Academy, it's not being endorsed by Bosnia. So there's always politics. And now the other issue is that now you have all these people, casting is available everywhere, most of the time, and soft roll, but the bracing is a major issue, especially when you are looking at a global program. So, you know, I don't know where's the price here for you guys, but I think in the United States and Europe, between 500 and 2,500 is probably pretty, you know, kind of standard for Hanger and all these guys. But in low resources, they, you know, they have these kind of things. You know, a father actually sent me these pictures from Peru. He couldn't buy any, and he's like, okay, well, I put these 2 shoes and a bar in between, and actually it worked pretty good, because the shoes were very comfortable, and you just need to keep the feet like this or sleeping. So, but because this is a big problem, then we decide to tackle and develop a brace that would be high quality, affordable, comfortable, that any kid in any part of the world can use. Because Dr. Ponseti's philosophy is that, you know, any kid in any way, they should have the Ponseti method in the meaning of correction, and then they will still be successful. So, you know, we work with a lot of organizations. The main one is BBC International. That's the organization, the company who makes the shoes, actually, and they have been absolutely fantastic with us for making it very affordable. So, and that's the other reason, through the University of Iowa, because it was all done through the university. You know, we did a patent through the university, and then the university gave the patent to Clubfoot Solutions, which is a non-profit, as you know, organization for the bracing. And I believe that, and you may correct me, there's almost 100,000 braces now being used in 90 probably more than 9 countries. And the key here in developing countries actually is that the brace, like I was in Colombia just about a month ago, they use the same shoes 5 times until it torn apart. So the return of investment is huge. And in Colombia, I think the price of the brace is maybe $60 or something.
Yeah.
Something like that. I mean, you use it 5 times, that means like $10 per kid. I mean, you cannot beat that. And it's absolutely phenomenal, the response. And the other thing is, in many countries, and you can see these pictures over here, in many countries, the kids don't use brakes, they don't use socks, because it maybe it's too warm. In Pakistan it's like 120 degrees or something. So they just use it because this material is breathable. I think the shoes are made in the Reebok.
Like children's Reeboks.
In the Reebok company in China or something. So it's been a great help for people in all over the countries, and I hope that we can continue supporting this program. I mean, Todd, I'm just here on the side. And so what happened moving forward? One of the things I think we have a big challenge in the United States. That's the reason why we continue offering a fellowship. Anybody that wants to do the fellowship is actually funded through a family from New York. It's the New Hour Fellowship. It's for 2 weeks. I think it's extremely helpful, I can tell you. Now globally, about 6-7 years ago, we were able, with the Rotarians, I'm a Rotarian too, we were able to convince Rotary International to allow the creation of what's called a Rotarian Action Group. It's a group just dedicated for Clubfoot, and this is all for developing countries. I was in October at the World Organization. I have the honor to present the program there because, as you might know, Rotary is finishing up the polio program that they have been doing for 30 years, and now polio is pretty much under control. They are looking for other programs, and that's why we try to sneak in there and say, hey, this is a pretty good one. It's working great. Actually, based on the numbers, this study was very important because it shows that the effectiveness of the Clubfoot is $18. You can compare with all the other effective at the global level. Okay, and the programs that we have now, we have these programs. We have a couple more. This is maybe a year old. The return on investment for the Rotary programs, which already has been about over $500,000, is $3.46 per kid. I don't know if you can have a program that is this effective. Because it's all based on training and working with the orthopedic societies and introducing the brace for them at low cost. And so it's really been an amazing program, and I don't know what will happen, but I hope that Rotary will take consideration for making it global, because there will be hundreds of thousands of kids and adults that will benefit from Dr. Mercir's wonderful method. So that is kind of the dream in Iowa. And the same way that the polio, all the disability, hopefully Mercir can also take that from the world. So it's been a very exciting time. I was very, very lucky and honored to work with Dr. Mercir for so many years. And I'm very lucky to work with the team and residents and fellows that come to visit our center. Tom Cook is professor in public health. We've been working together for 15 years. He's the one who really taught me thinking about system stuff instead of just when to do the anatomy. And Kathy's been the program manager. And I have to say that my wife has taken a lot of allowing me to do a lot of work and being out of the house and support me for all these years. So thank you so much for your attention.